I always say to folks, and I'll say it again today, you know, what one lesson that I think was driven home is when people talk about the public health infrastructure, it's not just your public health department, it's all of the community organizations and the faith-based organizations that work with us every day to ensure that all folks have what they need to be healthy. But with that, we can go to the next slide. I'm going to run through a slide deck pretty quickly, I hope. And then, you know, what I'd really love to do is obviously take questions and hear your comments. But I thought we are in this different phase. Things are much quieter. There's much smaller numbers of people in the hospital and people dying. We've spent some time reflecting on what we've learned both formally. We had invited an entity in to do a formal review of our actions, but we've also, you know, reflected inwardly and with some of our stakeholders. So I thought I would share a few of the lessons that we've learned, and then, you know, talk about a limited set of strategies that perhaps can help us move forward. So we can go to the next slide. You know, one of the biggest issues is, and we can go to the next slide, is that we continue to see massive inequities in health outcomes. And I put this slide up because this is mostly data that, you know, goes in some cases through 2022. But what it does is it gives us an opportunity to understand that in our county, as well as in many, many places in the United States, we have huge differences in people's health outcome, depending here, as you can see, on the color of someone's skin or their ethnicity. And in other accounts, we'll show some data about the resources and the poverty levels. But it's astounding that, you know, in LA County, Black residents on just about everything we measure have much worse health outcomes than others. And this is, although it's very easy to go to a narrative that, you know, in some ways blames people for those poor outcomes. They're not taking care of themselves. They're not accessing the resources that are available. They don't get into healthcare. We know that that's actually not true. And we'll look at some COVID data in a second. And that really this reflects longstanding inequities in people's access to what we call health affirming resources. And what is it that you actually need to be healthy? And the data is very clear that it's not just about either your access directly to healthcare, although that certainly is important. That accounts for about 20% of what we're going to see in outcomes. Nor is it about your individual behaviors. That does, of course, have an impact, but that's somewhere around 10 to 15 to 20%. And the rest is really rooted in where you live and where you work. We'll go to the next slide. And we certainly saw a lot of that during COVID. What's most astounding during COVID, this is a look at our case rates by race and ethnicity, is that every time there's a surge, you know, which is where you see those big upswings in the graph. Those are our surges. We had, you know, five of them, two really pronounced during the winter, two others less pronounced during the summer. And then this last winter, also, as you could see, we went up a little bit, but not as dramatically. But every time we have a surge, the differences by race and ethnicity become profound. With our Latinx and our Black residents having the highest case rates. Next slide. And you see the same pattern, you know, sadly, on death rates, where Black and Latinx residents really throughout this pandemic have had the higher death rates. Next slide. And it's not limited to just looking, we don't just look at the data by race and ethnicity, we also look at it by the area poverty levels. And in those communities with higher levels of poverty, more residents living below the federal poverty limits. And you can see that with the gold line and the blue line. There too, you saw, particularly during our surges on case rates here, you saw a similar pattern where, particularly in the winter, people living in communities with higher rates of poverty did far worse in terms of their infection rates than others. The next slide. And, again, similar patterns, sadly, on deaths, just lots more deaths occurring in communities with high rates of poverty. Next slide. And while the vaccines, super important, and you can see that here, fully vaccinated people, these are hospitalization rates, do far better than people who are unvaccinated. They're not an equalizer. And just the fact that you're vaccinated does not erase the fact that there's an impact based on the color of your skin and where you live and where you work on whether you're going to be hospitalized. As a matter of fact, people who were fully vaccinated, as you can see here, had higher rate of hospitalization if they lived in high poverty community than people who were completely unvaccinated and lived in wealthy communities. And the magnitude of the difference between the protections that vaccines provided is also pretty different. So if you look at people living in the wealthiest communities, yes, vaccines provided decent protection from getting hospitalized. It's about 1.5 times less likely to be hospitalized if you were fully vaccinated. But if you lived in a community where the poverty rates were high, you had about an 8-fold increase in your risk of getting infected if you were unvaccinated compared to people who are vaccinated. So vaccines, super powerful across the board, but they are not an equalizer. Next slide. And again, a similar pattern, sadly on deaths, where fully vaccinated people living in communities with high rates of poverty are dying at a higher rate than unvaccinated people living in our wealthiest communities. Next slide. And the other difference that you can see when you look at our data is where are people getting infected in terms of work sites, and the reason we put this up is it's really important to note that while many of us may have been able to work from home or from a private office space during the pandemic, lots of what you see here are people who actually, especially where you see the highest rates, are people who actually had to go into work. So you could see that the number of outbreaks that were experienced at work sites varied by the kind of work, where people working in retail, in food, in manufacturing had significantly higher exposures and were involved in more outbreaks than people in some of our other service sectors. Next slide. And so when we look at all of this data, and obviously some data I wasn't able to share today, what some of the lessons we learned are, what were the factors that contributed to the COVID inequities? Because it would be important to know this so that we can try to avoid a similar scenario in any other, sort of communicable disease spread. Increased exposures was certainly at play here, and you saw that because rates would kind of equalize when we were in low community transmission. But as soon as we were in periods of high transmission, the gaps grew pretty wide. And that's because many essential workers are working at sites where they're in close contact with lots of other people, lots of other workers and customers. And if there's a period of time when there's going to be high transmission in the community, then that means when you're working at these sites, you're going to have a lot more exposures, and the potential for you to get infected is going to increase pretty significantly. And many of our lowest wage workers are the ones who are working in sites where there's lots of exposures. We see this at factories, manufacturing plants, the transportation sector. We see this in retail, grocery stores, food, places where food is prepared and served. And as you all know, lots of people working in these places are going to be folks who have lower wages than folks in other industries where there are going to be less exposures. We also know that many of our sort of lower wage workers are also living in communities where there's overcrowded housing, there's densely populated neighborhoods. They're working at sites where the ventilation may be poor or kind of non-existent. I certainly saw some of that at the beginning of the pandemic. And this all makes spread easier. So if you're in a place where it's super hard for you to isolate in your home, when you've been either infected or exposed, there's going to be more spread there. If you live in dense communities with less health affirming resources, it's easy for there to be spread as you are living in those communities. And for many, the issues related to ventilation at work sites became really paramount to making spread a lot easier. There's also, as we saw on that first slide, the fact that Black and Brown people in LA County, as in many other parts of the country, have higher rates of chronic diseases going into a pandemic. And the sad reality was that one of the risk factors for doing poorly in this pandemic, should you get infected, was if you had underlying health conditions. So you have groups of people who disproportionately are more prone to having underlying health conditions. That includes older people, significantly older people in particular, but it also includes, as we just saw, Black and Brown people, higher rates of diabetes, higher rates of asthma, higher rates of heart disease. And this all is associated with poorer outcomes for people who get infected. And then we all saw in real life, sort of real time play out the inequitable distribution of the kinds of resources that make all of us enjoy better health. So, when the president, and I was thrilled with this initiative, so don't get me wrong, but when he rolled out his initiative to distribute vaccines at chain pharmacies, if you look in places like South LA and some of the communities in San Gabriel Valley, you have hardly any chain pharmacies. You have independent pharmacies, but they weren't involved in that program that got rolled out at the federal level. So we have to pay attention to that. The same thing with clinics. Clinics became, for the entire pandemic, a really important and strong resource for residents. It was places where you could get vaccines, you could get test kits, you could get therapeutics. It's also a place where you could get services if you were sick. But we have a lot of unevenness in different parts of the county about the access to those health services. And then other things like who's got paid sick and family leave, that became critical, and it led in some places to people being able to access, COVID leave pay, because we have so many workers that don't have paid sick leave or family leave. And when you're telling people that they have to isolate for 14 days, that was at the beginning, then 10 days, and there's no paycheck coming in, that creates all kinds of hardships. The same thing with telework options. And this all differed, as we know, by where people were living and what their income was. So these for us is sort of a take home. It applies to so many of the other inequities we see. But I think for many folks, the fact that we could see this evolve over a very short time period made it much easier for us to understand the factors that were contributing to inequities, because it was right in front of us these past 3 years. Next slide. One of the other big learnings for us is sort of what is everyone's understanding of the role of public health? And we can go on to the next slide. The fact of the matter is, I'm not sure how many people knew this before the pandemic. I certainly experienced a lot of people in government not knowing about this, that public health has this very, very broad authority during a public health emergency. And that includes a pandemic. This authority rests within our department, but specifically within a county health officer during any kind of declared public health emergency. And the public health officer can actually declare that emergency. It does need to get ratified within 7 days by a board of supervisors, but it is in fact an independent authority that the health officer and the public health department are going to have. Now, the county board of supervisors also has the authority to declare an emergency and to take measures to respond to that emergency, independent of a public health emergency that's declared by a county health officer. But they cannot they cannot tell a public health officer not to declare an emergency. They cannot ratify it and not have it go in effect after 7 days. But during those 7 days, it would be in effect. I think almost no one knew that. The fact of the matter is that the LA County Board of Supervisors hires me. I'm the public health director, and then I hire the county health officer. I mean, I had, lots of folks assume that even if this was a public health emergency, that the person in charge would either be the sheriff or the person who heads up the emergency management response for the county, but that's actually not the case in a public health emergency because of the authorities that are vested in your public health folks. Next slide. So here is sort of the statute that it's California law that talks about all of the authorities that rest within a public health officer when there is a communicable disease. So one measure is declaring a public health emergency, but there are lots of other things that a health officer can do to prevent the spread of the disease. So let's go to the next slide. And that included a whole host of health officer health orders. Quarantine and isolation orders were in effect, business infection control. Y'all lived through this, individual infection control, particularly around masking, and outbreak management and mitigation. So these are standard authorities, and we use them all the time for other diseases, but that have never been at this scale. So measles outbreaks, hepatitis A outbreaks, any kind of communicable disease spread warrants quarantine and isolation orders. We actually have standing quarantine and isolation orders. So these authorities are not new, but many people had not experienced them until the pandemic. So there's the authority to declare a public health emergency, which after a few days does need to get ratified. But apart from that, there's a broad authorities on public health orders for to manage infection disease control. Next slide. Now, I know we all lived through this. And, the reality is that the vast majority of people actually complied with public health officer orders, these health officer orders. This is a study done by USC. They did it over many different points of time over these 2 years. At the point you see that big drop off is when the masking orders were in fact ended. The health officer order that required masking was rescinded for the public. Next slide. Same thing, these are on transit, sort of, which again stayed higher. We have a strong recommendation that people do still keep their masks on, and you can see that again, somewhere between 70–80%, really fully complied with the health officer orders until those health officer orders were rescinded. Next slide. This is on seeking care, and again, that was just recently rescinded, so you see pretty high rates there. This is for patients, not for staff. Staff still are required to wear their masks at healthcare facilities. Next slide. We could walk away from that saying 70–80%, that's great. But in a public health emergency, we actually need collective actions to keep each other safe. So let's not write off the 20–30% of folks who had a hard time with this. I think some of the challenges were pretty visible. We had non-elected officials. We had this whole notion that public health folks should not be making these big decisions, that, you know, there's no way that they should have that kind of authority. And that was a challenge that we faced from the beginning, and we still face it today. We had elected officials that would differ, you know, and express a different view from a public health official, not just here. This is across the country. And the reality is that public health is not set up for traditional enforcement. It has very limited capacity. You know, we can issue some fines and citations, but, you know, we're not the police, and we never really look towards having sort of police authorities around having people in compliance. So, you know, again, you know, sometimes with isolation and quarantine orders in the past, we've had to involve the police. We've had a person with TB, for example, that wasn't adhering to their to the protocol for isolation and quarantine and was exposing lots of other people. But in general, in those situations, the police were helpful on enforcement. But in this case, we had limited ability to enforce, and in many places, there was no way that the police were going to be part of any kind of enforcement strategies. We never requested it, but there also was a sense that, you know, nobody was going to really be able to help with that. And those are pretty big challenges. Yeah, you can go to the next slide. And you know, this is nonpartisan. Like, this is so, you know, just a recent example, the president, who obviously has supported the pandemic with resources and examples of support for public health actions throughout his tenure. But, you know, back in September, right before the primaries, you know, he declared the pandemic was over. Now, all the public health people were saying, you know, we're in a much better place, but let's not say it's over. And in fact, here in LA County, we started seeing, you know, sort of that rise again, you know, last November. And then we got this new variant that was really transmissible, more transmissible than anything we had seen, and we didn't know much about it. And it could have fueled, again, a big increase. Fortunately, it just fueled a small bump. But there's, you know, this idea of a mutating virus is why most public health people are very cautious about saying, you know, the pandemic is over. The WHO hasn't said it's over. We haven't said it's over. CDC hasn't said it's over, because we do have a mutating virus, and it's in that way it's unpredictable. But we could in fact see waning protections depending on the mutation. Next slide. Another you know, sort of key responsibility for us that we again learned a lot about was, what does it mean to provide effective information and communication? This is a general responsibility for public health. We always have this responsibility. We need to keep people up to date on what's going on, what they need to know to take good care of themselves and their families. We need to make sure this information is accessible culturally as well as linguistically. And then we have to be able to listen and learn from those people who are most effective so we can have strategies that actually make sense. But this seemingly straightforward set of activities that we do all of the time was up for some huge challenges during the pandemic. One is that this is a brand new virus, so the science was evolving really almost daily at the beginning. And that meant that our guidance was changing all of the time. And that created massive confusion. You know, like in March, we said, don't wear a mask. In April, when we found out that there was a lot of asymptomatic spread, so it wasn't just sick people spreading, but lots of not sick people who were spreading, we were like, put your masks on. We said it wasn't airborne, then we said it was airborne. These are big deals about sort of how to mitigate and what you should be doing around protecting yourself and protecting others. we also have, and I'm going to talk a little bit more about all of these, distrust in our regulatory agencies, and that really led to a lot of hesitancy on the new vaccines. And then we had massive spread of misinformation, which contributed to a lot of doubt and fear. So this was all then woven into this responsibility to try to make sure people have accurate information. Next slide. So let's just talk a little bit about some of these. With a new virus that's mutating all of the time, throughout the pandemic, we had different answers to just some very basic questions. How's this virus spreading? Who's spreading the virus? And what interventions are going to work and why are they going to work? And you all lived through that. And that is the reality. You cannot change that, and you cannot stay in one place because you don't want to confuse people because the information got complicated. So we have to acknowledge this as our reality and then do a better job understanding how we're going to communicate in a period of massive uncertainty. Next slide. We also have this issue, this history that contributes to vaccine hesitancy that we needed to pay more attention to. So, we all know, we all have examples of sort of the FDA approving drugs that then those drugs were super problematic. I know of, I was born and raised in Puerto Rico, so I'm very aware of the history around oral contraceptives and, people not knowing they're enrolled in a study, the clinical trial results were not properly presented to the FDA. There were serious side effects that didn't get reported, including that people died who were in the study, but those drugs got approved. We all know about oxycodone and sort of the sad history in this country of the FDA approval for that. And, there are many, many other examples, including, even the issues around e-cigarettes. So when people say, like, we don't trust the FDA, it's not necessarily because they are just hate government. It's because they've seen this history where they feel like the FDA may be in the pocket of drug companies and that elected officials may also be aligning themselves with moneyed interests as opposed to science interests. So we needed to pay way more attention to that history. Next slide. As we thought about what we were doing. And then, we had conflicting information from people pretty high up about what people should do. The whole fiasco around disinfectants. We had somebody who came out of the Pfizer network saying that the vaccine was sterilizing women. I mean, none of these things were true. But this level of misinformation, go to the next slide, made our jobs super, super hard. We had people thinking that you got vaccinated, you could spread the vaccine, that we had magnetic microchips. And the saddest reality was that oftentimes people are making money off of this misinformation. They're selling these videos and then they're doing direct sales ads on these platforms, making money as they're spreading misinformation. This is a new world to us in public health, but the reality is, and we can go to the next slide, that a take home for us is people don't necessarily trust government, and there are some good reasons for that. But in any ability for us to be able to have collective action is going to require that we deal with that, building that trust back. And that's not going to happen quickly. We can go back one slide. You can, yeah. So there are, the third sort of area where there's a lot of lessons to be learned is that we had some pretty big health system challenges. You can go to the next slide. I'm just going to touch upon a couple of these because, again, we all witnessed what this meant. We don't have a central data repository in this country. We don't have a we don't have one healthcare system. We have lots of privatized systems. And we don't have rules that actually require reporting to a federal data repository. So testing was a nightmare, like getting results, depending on where you live, depended on what you got. But good information about who's getting tested and what those results was and still is super hard to find. We relied on public health labs across the country. That was clearly insufficient. The private system wasn't linked to the public system, so much work had to be done so we could get data from private systems, including passing laws here, regulations here that required private data labs to report to public health. So this system was not set up to help us during a pandemic. Vaccinations, many providers just said we can't vaccinate people at this, at a high rate. So we're not set up for that. Private practitioners weren't able to even notify their patients. There was a problem with storing the vaccines. They didn't get any funding to do outreach and education in that privatized system, so they weren't doing it. And then for therapeutics, you all know you got to get those pretty quick after you get symptomatic, but oftentimes private practices don't have evening hours, they don't have weekend hours. People were going to have to go see a provider, go one place, get tested, find out if they're positive, then go see a provider, get a script, then go to a pharmacy, 3 stops to get your medication. And that was driving people, particularly people with no resources, not to be able to take advantage of life-saving therapeutics. So next slide. And you can see this, I'm just going to use monkeypox. It wasn't even just for COVID. But once we got the vaccines for monkeypox, that blue line at the top is the public health response to get those vaccines out. This is the number of doses that were administered. And you can see that it was the public health folks who were quickly able to stand up massive sites where thousands of people could come and get vaccinated again. Everybody wanted the vaccine at the beginning. And it took a much longer time for health systems, for the community, for even our pharmacies to be able to ramp up. They all ramped up, but when you're trying to get people vaccinated as quickly as possible, a 2-month ramp up is noticeable. And so again, these are sort of the limitations of how our data systems and our distribution systems are set up. Next slide. And while you might say, well, that's fine. That's why we have a public health system. We have a very poorly funded public health system, especially compared to what we spend on medical care. So public health gets very little money, and this is in a well-endowed county like LA. Our total per capita spending with all of the grants that we get, most of it is not county dollars, is probably at this point it's higher, but it was about $125 per person a year. And healthcare spending is closer to $10,000 a year. So that privatized system has a lot of money in it, and the public system has very little money in it. So yes, the public system needed to stand up. And fortunately here in LA County, we could, but this is not the way to sort of move forward with not better collaboration, not better capacity. We got to understand where these, what I call sort of blockages are, and then figure out how we're going to better integrate these two systems. Next slide. So I want to just talk for a minute about, sort of additional impacts over the last 3 years. We didn't just have a pandemic. We had a lot of other things happening. We had a lot of social unrest. We had economic devastation. And we had really significant increases in people reporting poor emotional well-being and the fentanyl crisis. Next slide. So just for a second, just to level set, I think most people know this, but fentanyl is a high potency synthetic opioid. It is legally manufactured and it is commonly used for pain control and with anesthesia in medical care settings, but it is also illicitly manufactured in labs or garages and has led to a lot of abuse. It's because it's so powerful. and this illicitly manufactured fentanyl is what's contributing to almost all of the fentanyl deaths that we now see. Fentanyl is super easy to make, super cheap. It's laced in all kinds of other drugs, so it's not just sold as fentanyl, which you would know what you were getting, but it's also added to pills that look like prescription medications. It can be added to meth, cocaine, heroin, and it takes a very small amount to overdose, and you can overdose very quickly. Next slide. So just so you can see here, this is just sort of, you can see this sort of steep increase in overdoses, and you can see that it started before the pandemic. So let's not fool ourselves about just like this was all pandemic induced. No, these trends have been alarming, and in fact, most of the increase that you can see, the steepest increase is associated with opioids and with fentanyl and meth. So those are what were driving this, but meth has the steepest increase of, fentanyl has the steepest increase of all in terms of contributing to overdose mortality. Mind you, a person who overdoses may have 2, 3, or 4 drugs that they just took that are contributing to that overdose. Next slide. And you can see that 26 to 39-year-olds are the group that's most affected by both in terms of numbers and in terms of their rate. But we also have much younger people in the 18 to 25-year-old group, and a significant number of older people, 40 to 64-year-old, that also have died from a fentanyl overdose. Next slide. So these are big challenges that I've just laid out, sort of how are we going to better integrate the healthcare system with the public health system? How are we going to do a better job on communication and building trust? How are we going to address the sort of devastating impact of inequities associated with race, ethnicity, and level of income? And how are we going to combat the sort of huge problems around substance use and mental health? Like some ideas, and then I want to just stop, but we can go to the next slide. One thing is, we're not going to get anywhere on addressing issues and inequities if we don't address the root causes. But a couple of things around the root causes is, where you live, where you work has such a big impact on your overall health. And part of that is like, what kind of resources are there available to support optimal health? And one of the saddest things for me right now is sort of we learned a very important lesson during the pandemic about the need for the social safety net, to make sure people had food, certainly housing in LA County. All of us are aware of that issue. We built up, some paid leave for people who were sick with COVID or had to take care of family members who were sick with COVID. We came up with housing support for many more people, including an eviction moratorium. We figured out how to deliver food and meals to people who really were struggling with food insecurity. We allowed people to be able to have access to Medi-Cal insurance without a lot of churning. And slowly but surely, you've seen over the last few months, we've dismantled a lot of that without putting in place what I think are some really essential long-term guarantees around a social safety net. So I think in the absence of that, it's really hard to make sure people are going to have the resources they need to be healthy. Really hard to be healthy if you're housing insecure, if you're food insecure, if you live in neighborhoods with lots of contamination in the soil and the air, some neighborhoods even in the water. So we're going to have to address that. And we're going to have to join with others to really address the impact of racism and address discriminatory practices that really make it impossible for people of color to thrive in our county, in our country. So that's big work, but it's work we can do and we have done in the past. And, my hope is we continue to find a way to work together on that. Second, next slide. Obviously, one of the lessons we learned at public health was that workers are not well protected. I mean, some of our unionized workers have better protections than others, but we saw so many violations, not just violations of COVID protection measures, but violations of all kinds of worker protections. So we got to fix that system. And there's some things I think we could do locally to really make our workplaces safer. And then we should all at this point be looking for those policy changes that are going to help our workers be safe at work, strengthening Cal OSHA, making sure that they have resources to investigate. Right now, it can take them 6 months. They can cite a place, but you can call in and say there's a violation, but it may take them 6 months to come down there and really, complete their investigation. That's too long for a safety issue that affects dozens and dozens of workers. Next slide. And I do think, this we have to work together on sort of building trust. One thing is, people do need to be clear about the public health and, sort of authorities. When there's a big fire, nobody starts questioning the fire chief. You don't start trying to tell the fire chief, where they should put their resources or, how they should deploy, how they should fight the fire. I guess some people do, but the majority of people recognize that the fire chief has that expertise and you want that person to be making those decisions. We're going to need people to feel the same about public health officials, that the expertise is here. You don't want these to be politicized decisions. You do want them to be based in the science, even if the science is confusing. Fighting a fire isn't straightforward either. People have to use their judgment and make judgment calls and do their very best. And then, always be reflective and learn. But those are the people with the most experience, and those are the people that are trusted and should be trusted. So, part of building trust is making sure there's a clarity on roles. And we do need to also work together to build a more collective, collaborative response. It took us a while to get money to people, to get food to people. So we should be very prepared to use our ability to organize together and collaborate together to roll out faster responses on some of the more complex needs that residents and workers will have in businesses. I mean, it just, the pandemic sort of really underscored how interconnected our systems are going to need to be. And then we're going to have to figure out a better strategy for addressing the proliferation of misinformation. Part of it for us is just recognizing where people get their information from and creating more capacity by giving folks more resources in local communities to be those trusted public health ambassadors. Next slide. And then obviously, I think we're going to need to do more around investing in the public health infrastructure, acknowledging that infrastructure is not just the public health department, but all of these other entities that stand up every day, not just during a crisis. And being able to really assess those limitations that the privatized system has around emergency response, so that we're well prepared to stand up an appropriate response in any future, whenever we have any future needs. We can go on to the next slide. And I'm not going to spend a lot of time here, but I do want to note that, even implementing harm reduction strategies for many folks, that's a new way for us to think about substance use disorders. But the first job here is to keep people alive and stop them from overdosing. So this is what we need to do to stop people from overdosing. There's a lot more we need to do to prevent people from becoming addicted to illicit drugs, to help people really understand how to get help. But right now, we need to distribute a lot more naloxone. I hope all of you know how to get naloxone for your business, for your organization, in your household, if you have people who may be at risk. We need to be able to make sure that people who are using have access to the services that will help keep them alive and may help connect them when they're ready to support for addressing their addiction. But we don't tell people with diabetes to go lose weight and exercise more before we treat their diabetes. And we should stop thinking about substance abuse, people who have a substance abuse disorder differently than we think about people with diabetes. We would do good to have safe consumption sites where we can prevent people from overdosing and connect them to things that they need. We need more prescribers for medically assisted treatments that are available, but often not embraced. But those are ways to really make sure that people who are ready to treat their addiction can have access to some very successful treatments. And then obviously we need a network that can meet any kind of demand for treatment. Next slide. So, I presented a lot. I'm happy to take questions. These are complex times we all live in. My takeaway from the pandemic response is that nobody can go it alone, not in our communities and not amongst ourselves as leaders of organizations. We are very interconnected. We need to work together, and we need to be able to do that in a way that's respectful, honors our diversity, but does not let that diversity stand in the way of making sure we do what we are intended to do, which is have a community of people that can take care of each other. So with that, I'll stop and happy to take any questions, comments. Doesn't even have to be questions.
I think our first question is from Valerie Martinez.
Hi there, Dr. Ferrer. First, thank you so much, not just for being here, but for being in the position you're in. And by the way, still being in the position you're in. Given everything you went through, I wouldn't be surprised. I wouldn't blame you to go find some wonderful corporate job where you're able to just kind of be for a minute. So thank you for all of that. In keeping your presentation was phenomenal and incredibly it's so much incredibly informative in terms of where we were and where we are and what that means. We're a bunch of public affairs folks, and so most of us deal with crisis management and all that sort of thing, and our brains are wired to plan for the crisis so that when the crisis happens, there's no thinking, you just implement, right? And so are there things we can do while we're not in the pandemic that are actually happening? Put all of those lessons learned into kind of an action plan with training and outreach and systems, and a package of bills that would move all of those, or at least a vast majority of those items that you called out forward, because right now people aren't in defensive posture, right? So people are now focused on the other 15 things that are scary to them. So yeah.
You're the better person to sort of tell me like how we could support you on this. Like I can identify like what didn't work well, but you're way smarter than I am about what we could do differently right now to be better prepared. I think we were all caught off guard by sort of how much uncertainty there was. And, I have I think my view might be too simplistic, but I feel like what hurt us the most about the uncertainty was that folks weren't already trusting us or coming to us for all of this information. Like some people know to come to public health for information, but they weren't necessarily used to coming to public health for information. They were getting, I don't know where, people got their health information from lots of different places, including from many of you. I mean, you are visible in a way we weren't, and you continue to be visible in ways we're not. And I think the time is now for sort of the public affairs people to become the trusted voice in the community. because you're providing them with lots of good information that they need for other things, not COVID related. And that's certainly the lesson our team has taken home, is like, I don't want people not to know who we are. And the fact to me that's most frightening was, I did a lot of door knocking. I would talk to people in their houses, and they would actually say to me, oh no, we like you, but you're being lied to. And they would actually show me videos about like people getting chips, in their vaccines. And they really believed it. And they did not believe me. And I would say that that's not possible. Like, these are manufactured videos. No, señora, they would, they would just say, no, this is the truth. And, the work to sort of fix that, I think, has to start now. Because the proliferation of misinformation, some of it was very intentional during this pandemic, very intentional. And some of it was just very misguided. But either way, having more, I'm going to call them reputable, I don't know if that's the right word, reputable sources of information that can be trusted in a community besides us would be helpful. And you are those voices. So I think one thing is for us to collaborate on other efforts that are not related to COVID. Like, for example, right now we have a very big campaign to get everybody trained in hands-only CPR. We'd like to hit 500,000 people trained in hands-only CPR. This is a feel-good campaign. And it really helps. It's a 5-minute training, but it can make a huge difference. So my sense is, if people know that, we all stand for that now, and they're coming to us for that, then maybe when, there's the next pandemic or the next need for us to ask communities to do things together, they will know who we all are. But I would ask you to tell us what you think would make a difference, and then ask us to sort of partner with you on it.
Thank you.
So.
Okay, our next question is from Nancy Ferrer.
Hey, Nancy.
Hi, and thank you so much. Dr. Ferrer, I'm just in awe. I am so impressed, and even more so having heard you speak for this extended time. I heard you so much on the radio during the pandemic. And I wanted to ask, I guess, about leadership. How did you take care of and support the people on your team during the height of the pandemic? And how do you take care of yourself and your own health and mental health? This is something I've really struggled with during the pandemic, and I would love to understand how you have gotten through it and with such strength. Thank you.
I mean, the only way I got through it was because I have a team. So let me just be clear, like, I was never alone, and I have an amazing team. I'm not sure I did a great job, especially in the first couple of years, of sort of how we took care of each other. I mean, we did, acknowledge how stressed we all were. But it was super hard to figure out what we could do. We didn't have a bench. I mean, I will just be honest about that. We just didn't have a bench. So, it was very, when people took breaks, it wasn't like there was somebody to step in. What would happen is, when people needed to take breaks, and they did, there would just be more work for the 30 people who were already like working around the clock. So I think we did a bad job. I mean, I think I did a bad job on making sure that, in the height of the crisis, we were making it possible for people to take care of each other. I mean, I remember at one point I just sort of said, like, could we have quiet time? Like, could we not send or receive emails between 10 p.m. and 6 in the morning? And my team said no. Some of them were at home, and their kids were at home. I mean, people were in different places, but some of the team was at home, and they had kids in school, and they said, we work at night. Like, there's no way, like, we can't do that. Like, and I remember just thinking, like, oh my God, like, this is impossible. People were getting like 4 or 5 hours of sleep, like weeks and weeks and weeks on end. I took away all vacations for a while. And then, so obviously if you had an emergency, I mean, people were sick, people had emergencies, family emergencies, or got COVID or whatever. I mean, but in general, there were no vacations here for the first 6 months, no vacations at all. So, I'm glad you're raising this because no one else has really raised this, and we probably need to go back. I mean, what we've raised is we have to have a bench. And I've raised it, frankly, with the board of supervisors and the CEO, like, and we did finally get more positions. Like we can't be so lean at the top, that we have 30 people and nobody behind these 30 people. So I don't think we did that great a job. I mean, I think as people are, people here are super committed and super strong and everybody figured out like what they needed to do for themselves to be able to get through a really, really hard times. I know for me, for the first few months, like I just stopped exercising and then I was just like, this isn't going to work. So I'm putting this back in because, that would be like stress relief for me. I think other people did the same with other things, started doing yoga again, just, knew that they needed to take half an hour to an hour and just do some self-care stuff. We implemented at work, like everybody gets 30 minutes during the workday, paid 30 minutes to do some, self-care stuff. We so you could code it. It's kind of a training code, but you could do whatever you needed to do. Take a walk, take a yoga class, whatever. And it was paid. And my expectation was, again, that people would take that time. But I have to say, some people never took that time. Like they didn't ever feel like they could take that time. So, did that really help? Maybe for some people, but for a lot of people it didn't because the issue was workload. And I don't know, I'm sure you all felt the same. Like the work was it just never ended. And there was such a big crisis at the beginning because we were trying to do things and we had no systems to do them. So we were trying to create systems while we were doing things. So it really made it super, super difficult. And, I'm blessed because I just had an amazing team. And an amazing amount of support, frankly, from, you all, the community, a lot of attention to the haters, but we got way more love than we got hate. And that just didn't get a lot of attention. So, and
to that point, we appreciate the self-reflection a lot, but no one here is going to hear you saying that you did a bad job, just so you're clear.
Well, there are things like that you've got to like look back and say, what else could I have done? What else could we have done? So I think Nancy, you raised a super important question, and probably all of us should go back and think about, like, during an emergency, like, how do you make sure your team is going to get taken care of? And I think for some of us, that's harder than for others. I'm a person that's just used to, like, you just plow through, just plow through and, get up in the morning and know it's a new day and have a new chance to do whatever it is that needs to get done. And, but that doesn't necessarily help everyone. So.
Okay, we had one last question, and I know we had a hard stop at 10. So Helen, if you could unmute yourself.
All right, thank you. Thank you, Dr. Ferrer, for your presentation and all this time. I was wondering if you could talk a little about the impacts of COVID on health regulations and oversight on community events. Things like Taste of the Cities or Taste of the Towns. There's much concern over, the handling of like food items when you're out in public events now, like pre and post COVID, and some of those processes have changed.
Yeah, it's a great question, Helen. I mean, I'm not going to be able to give a definitive answer. I mean, one thing is, we have some regulations that are changing, but with all your community events, if food is being served, you already have requirements from us on some permitting that has to happen. And that allows us to go to those events before you open to make sure that the food handling side of things is done well. And I will say, at this point in time, transmission is lower, severity of illness way lower, few people dying. Some of the concerns that we had before about, gatherings are really no longer during, right now with the variants we have circulating right now are no longer top of mind for many people. I mean, we always urge people who are very vulnerable to be careful in those kinds of settings and use protection. That includes, wearing a mask if it's going to be super crowded and you're in the high risk category. But in terms of sort of the handling of food, like nothing's really changed. I mean, we still have the possibility of, there being transmission of, bacteria in particular, with improper food handling. And we still have regulations in place and we still have rules that vendors need to follow. So we would urge you, if you're doing those large events, to make sure you're touching base with us. You know what the rules are. And I know for the larger events, we do go out to make sure that you're, in compliance. I mean, not for the smaller community events, but we anticipate that the rules are being followed. So Helen, if you have a particular event and you just need more information on who you should be in touch with here, just email me and I will put you in touch with the environmental health folks.
Thank you. Yeah, I know previously nonprofits were offered exemptions, and we were one of those nonprofits that had received exemptions, but that process has changed.
Yeah, I mean, I think you're exempt as an individual vendor, but the community, like if it's a community event, you do have some requirements. Like whoever's the sponsor of the community event does have some requirements. So around food handling, but I wouldn't have those details, but I can put you in touch with the people who will.
Thank you so much.
Thank you. Thanks, everyone. It was a pleasure. I appreciate everything you all did, and hopefully we really have turned the corner for good, and we get to partner with you on lots of other exciting programming and projects. I'm going to do a plug for Heart Heroes. We think this is a fun project. It really will make a difference. It will save more lives. It's pretty easy to do, and we could use all of your support on that. And again, you can email me. I'll put you in touch with our team and we can get you trained. We can give you kits so that you can become trainers in your communities. And we can go ahead and make sure lots more people have this life-saving skill. So.
Thank you, Dr. Ferrer. It was an honor to have you. We'd love to have you in person at some point.
Yeah, absolutely.
I also want to
I'm
thank.
happy to travel. I mean, my schedule's super busy, like that's why to fit this in. But no, I do in-person events all the time, and happy to come and join you at some.
We appreciate your time, and I want to thank Judith Vasquez on your staff, who was great.
Oh, yeah.
Together.
She's amazing. Yes.
And a friend of mine, Hema Morales-Meyer.
Oh yeah.
Who was my go-to for COVID information.
Yes, she's a lot of people's go-to. She runs all of our clinic services, so she's amazing.
Yeah, she's great. So
I'm glad you know her. So thank you. Thanks for inviting me. And again, look forward to continuing to collaborate.
Thank you. Appreciate it.